Proper.
You good?
Yeah.
All right. Good afternoon, everyone. Welcome to October 19th Endocrine Grand Rounds. Thank you for your patience as we handled some technical difficulties. It's my pleasure to introduce Dr. Prasanthi Gandham. Dr. Gandham is a product of the University of Cincinnati School of Medicine. She did her pediatric residency training right here in Louisville at Norton Children's Hospital and the University of Louisville. She then did her fellowship training at VCU in Richmond, Virginia, and then began her professional career at Akron Children's before we were able to recruit her away, and she joined us as a faculty member in 2019. Since that time, she has been very active, and she has had a number of leadership roles, including taking on the directorship of our metabolic bone program, as well as being our physician lead for our newborn screening program here in Kentucky for endocrinology. And so it's very appropriate then that her topic today is on neonatal diabetes. And so please welcome Dr. Gandham. Thank you very much for being here.
Well, good afternoon, everybody. Thank you so much for bearing with us through some technical difficulties. Without further ado, we'll go ahead and get started. We're going to be talking today about neonatal diabetes, an overview. With me, I have no disclosures. So the objectives for today's talk are to review the underlying genetic causes of neonatal diabetes mellitus, to review how specific genotype impacts phenotypic presentation in patients with monogenic diabetes mellitus presenting in the neonatal period, to review other causes of hyperglycemia in the neonatal period, and to discuss the treatment and long-term follow-up of patients affected by neonatal diabetes. So let's start with a clinical case. We have a term infant who was born via repeat C-section. The pregnancy was uncomplicated, but the infant was noted to be small for gestational age at birth. The birth weight was 2.37 kilograms, which is about 5 pounds, 3.6 ounces. There was routine newborn care, and the baby was sent to the newborn nursery, but the initial glucose after feeding was 118 milligrams per deciliter. The infant was breastfed PO, but there was an insufficient PO intake, and so eventually the baby did require supplementation with formula. She was noted to have sort of a mild persistent hyperglycemia with a peak glucose of 171 while she was in the newborn nursery, but then after that there was sort of a modest downward trend in the glucoses. She had a workup, which included looking for infection. She had urine CMV that was negative. She had a head ultrasound, which was also normal, and she was eventually discharged home on day of life 4. She presented to her pediatrician just for a newborn well child check, and at that time, 2 hours after a feed, her point of care blood glucose was reported as HI high. So depending on the meter being used, that's a blood sugar greater than 500 or 600. She was, of course, immediately referred to the emergency department for evaluation. On arrival to the ED, her initial labs showed a serum glucose of 507, her pH was 7.44, a bicarb was 23, and there were negative urine ketones. She had a C-peptide, which was low at 0.3. Urinalysis did not demonstrate any evidence of infection. Blood and urine cultures were obtained and eventually came back as no growth. And she was admitted to the PICU and started on an insulin drip. An ultrasound was obtained while she was in the ICU and demonstrated the presence of a normal-sized pancreas. And we have another clinical case. So you have a 6-month-old female infant with a history of trisomy 21, noted to be in distress by mother. They presented to an emergency department where she was noted to be in SVT, not responsive to adenosine ×2. Lab evaluation demonstrated a glucose of 452 with a pH of 7.21 and a bicarb of 9. The C-peptide level was obtained and was found to be low at 0.5. Pancreatic antibodies were obtained, and the patient was admitted to the PICU and started on double-back therapy and insulin drip for treatment of diabetic ketoacidosis. She also had an ultrasound obtained and it demonstrated presence of a normal-sized pancreas. So let's talk a little bit about background and epidemiology of neonatal diabetes mellitus. This is a rare genetic condition presenting in the first year of life. This incidence varies based on ethnicity, and it occurs, in about 1 in 90,000 to 1 in 160,000 live births. Neonatal diabetes mellitus is characterized by severe hyperglycemia requiring treatment, and it occurs between the neonatal period and infancy. Most commonly, it's presenting before 6 months of age. The disease is explained by two major groups of mechanism: abnormal function of the pancreatic beta cell or malformation of the pancreas. And neonatal diabetes mellitus, interestingly, may be transient or permanent. Generally, the hyperglycemia seen in neonatal diabetes mellitus is associated with insufficient or absent circulating insulin. So there are actually a number of causes of neonatal hyperglycemia outside of diabetes mellitus, and the presence of hyperglycemia in the neonatal period alone is not sufficient to confer a diagnosis of neonatal diabetes. Hyperglycemia in the neonatal period is quite common, especially in low birth weight and preterm infants who are much higher risk for hyperglycemia, and about 25 to 75% of patients who kind of fall into that low birth weight or preterm category will present with hyperglycemia. Most often it's going to present in the 3 to 5 days after birth, but it may present up to 10 days of life, and it typically resolves within 2 to 3 days of onset. There are a number of possible etiologies to explain neonatal hyperglycemia. Total parenteral nutrition is used very commonly in neonates, and that can contribute to hyperglycemia. Certainly sepsis or infection of any sort. Oftentimes critically ill infants are on a number of medications that could contribute to hyperglycemia. They have increased counterregulatory hormone response, and they have relative insulin insufficiency in the setting of their critical illness. A diagnosis of neonatal diabetes, however, should be considered in any infant who has insulin-dependent hyperglycemia. If there's persistent glucose elevation, so glucoses that are greater than 250 milligrams per deciliter persistently, likely they are going to need treatment with insulin, at least temporarily. Hyperglycemia lasting longer than 7 to 10 days. If you have severe acute hyperglycemia, regardless of the duration, so we were talking blood sugars greater than 500 milligrams per deciliter, or if there's no alternative etiology to explain the hyperglycemia. A monogenic cause of diabetes is more commonly found in infants greater than 32 weeks of gestation, but it's important to note that even in infants who are younger than 32 weeks of gestation, a monogenic cause of diabetes is found quite frequently, so in about 30% of those patients. And so irregardless of your suspicion, if a child is presenting with insulin-dependent hyperglycemia in the neonatal period, genetic testing really should be obtained, as indicated in all of these children. I want to take a little bit of time to talk about pathogenesis, go back to our med school days and talk about insulin production. So insulin is synthesized, of course, as pre-proinsulin in the ribosomes of the rough endoplasmic reticulum of the pancreatic beta cell. The pre-proinsulin is cleaved to proinsulin, which is transported to the Golgi apparatus, where it is packaged into secretory granules located close to the cell membrane. Proinsulin is cleaved into equimolar amounts of insulin and C-peptide in the secretory granules. The process of insulin secretion involves fusion of the secretory granules with the cell membrane and exocytosis of insulin, C-peptide, and proinsulin. After feeding, when the blood glucose concentration increases, the glucose in the extracellular space of the beta cells, of course, increases. The glucose molecules are then transported into the cytoplasm of the beta cell by facilitated diffusion, most commonly across the GLUT2 receptor, which is located in the plasma membrane of the cell. The glucose is then phosphorylated by glucokinase, which is also known as the glucose sensor of the cell, and this results in an increased metabolic flow rate, an increase in the ATP to ADP ratio. The ATP then binds to the ATP-sensitive potassium channel located on the cell membrane of the beta cell, and this causes a depolarization of the cell. The channel protein is associated with the second protein, which is known as the sulfonylurea receptor, and of course, this is the site of action of the sulfonylurea medications. But once the cell is depolarized, a voltage-gated calcium channel on the beta cell opens, and this allows calcium to flow in from the extracellular space. And the increase in free calcium concentration is what then triggers the glucose-induced insulin secretion and exocytosis of the secretory granules. So infants who are presenting with neonatal diabetes most commonly will have a monogenic cause of their diabetes. The genetic mutation is found in about 80% of children with neonatal diabetes mellitus, and the number of genes associated with neonatal diabetes continues to increase over time. Currently, there are more than 20 known genetic causes that have been identified. What's interesting really is that the specific clinical presentation of diabetes in the neonates varies based on their underlying genetic etiology. So this is just a list meant to show you the number of mutations that have been identified and the fact that many of them have a different inheritance pattern and a variety of different features that, that patients might present with. We'll take a little bit of time to go over some of the most common mutations. So in a large series of about 1,000 patients diagnosed with neonatal diabetes before 6 months of age, causal mutations were found, like I said, in about 80% of the cases. Mutations in the potassium channel genes were the most common, and but they were identified less frequently in consanguineous families, and in families where there's consanguinity present. Sorry, I can't say that word today. Syndromic forms of diabetes tend to be most common. The first identified mutation that causes neonatal diabetes, however, was changes in the 6q24 locus. It's most often caused by paternal uniparental disomy of 6q24, partial duplication of the paternal 6q24 allele, or relaxation of the maternal 6q24 imprinted locus. It is the most common cause of transient neonatal diabetes mellitus, and it affected infants present very early in life. So typically within the first week of life, but about 93% of cases they'll present before age of 1 month. And then before the age of 1 month in 93% of cases, and before the age of 3 months in 100% of cases. They have additional features, including an umbilical hernia, macroglossia, and genitourinary defects, and about up to 15% of those affected, once they go into remission, will develop hypoglycemia, the etiology of which is unclear. Patients with 6q24 mutations typically do not have complete insulin deficiency, and so presentation with DKA is quite rare. Insulin therapy is oftentimes required for these patients in the early stages of life. They oftentimes will go on to develop hypoglycemia, like I said, but then when they have recurrence of their diabetes, usually in adolescence or in young adulthood, sometimes they can actually respond to oral anti-hyperglycemic agents, such as those that we use in patients with type 2 diabetes. So let's talk a little bit about mutations that cause abnormal beta cell function. The two most common mutations are mutations associated with the potassium-sensitive ATP channel that we just talked a little bit about. They're the second most common cause of transient neonatal diabetes mellitus after 6q24 mutations, but they're the most common cause of permanent neonatal diabetes mellitus, accounting for about more than 50% of cases of permanent neonatal diabetes mellitus. The potassium-sensitive ATP channel is an octamer. It's formed from two types of subunits. There's the KER6.2 subunit, which is encoded by KCNJ11, and then there's also the SUR1 subunit, which is encoded by ABCC8. And you can have mutations in either one of these genes that can cause neonatal diabetes mellitus. Typically, it's transmitted in an autosomal dominant fashion. As we noted earlier, the postprandial rise in glucose increases the ATP to ADP ratio, and that's what ultimately results in insulin secretion. So when you have an activating mutation in the potassium-sensitive ATP channel, the channel remains constitutively open, and you can no longer control membrane potential in response to glucose, which results in inadequate insulin secretion and diabetes mellitus. Children with mutations in either of these two genes tend to present a little bit later than kids who have 6q24 mutations. So the median age of presentation is about 9 to 10 weeks. About 30% of cases will present before the age of 1 month, and then the majority of cases, about 66%, will present in the first 6 months of life. About 30 to 75% of patients will present in DKA because there's relatively greater insulin insufficiency in these patients than in patients with 6q24 mutations. What's interesting is that there's actually a high number of potassium-sensitive ATP channels in the brain. And so children who have mutations in KCNJ11 or ABCC8 mutations are at very, very high risk for neurocognitive comorbidities. And so we see a spectrum of neurocognitive impairment, which includes decreased ability for reasoning, reading and vocabulary difficulties, trouble with auditory working memory, signs and symptoms of sleep disturbance, attention deficit hyperactivity disorder. And they also have delays in learning, social, emotional, and behavioral development. There's a syndrome called the DENS syndrome, which stands for developmental delay, epilepsy, and neonatal diabetes syndrome. And that's sort of the most severe clinical spectrum of the neurocognitive comorbidities that we see in children with KCNJ11 or ABCC8 mutations. The thing that's most important to know about children with mutations in the potassium-sensitive ATP channels is that they can oftentimes respond to sulfonylurea therapy as opposed to insulin. And we'll talk a little bit more about that moving forward, but they tend to have improved glycemic control with use of sulfonylureas compared to use of insulin. And they can also have improvement in their neurocognitive comorbidities with the use of sulfonylureas compared to insulin. So very important to know if somebody has a mutation responsive to sulfonylurea. So the third most common cause of neonatal diabetes mellitus is an INS mutation. It causes about 20% of permanent neonatal diabetes cases. There are actually autosomal dominant and autosomal recessive forms of NDM caused by INS mutations. In the autosomal dominant form, you have abnormal folding of the proinsulin. This leads to stress and apoptosis of the endoplasmic reticulum, which can impact beta cell growth and development and eventually cause beta cell death. In the autosomal recessive form of this condition, you have abnormal beta cell transcription, which may affect insulin promoter production directly, and the autosomal recessive forms of this condition tend to be more severe than the autosomal dominant. In keeping with the more severe presentation, kids with autosomal recessive mutations in INS tend to have a lower birth weight, minus 3.2 standard deviations, compared to those with autosomal dominant mutations who maybe have a low birth weight at minus 2 standard deviations. And they tend to be diagnosed earlier as well because they have more rapid beta cell death. And so they typically will be diagnosed maybe within the first 1 to 2 weeks of life compared to around 10 weeks of life. And then as far as glucokinase mutations, it's just interesting to note that if you have a heterozygous mutation in glucokinase, which as we discussed is sort of the glucose sensor in the pancreatic beta cell, heterozygous mutations will actually cause MODY2, and this just results in a mild fasting hyperglycemia. But if you have a homozygous mutation in glucokinase, then you can actually present with neonatal diabetes mellitus. And this causes a permanent form of neonatal diabetes mellitus. Typically, insulin therapy is required. Okay. And then we talk just briefly about a few of the mutations that cause abnormal pancreas morphology. So the most common mutation is in GATA6 haploinsufficiency. So GATA6 is a transcription factor. It's critical for pancreatic development as well as for other endoderm-derived tissues. It's actually necessary for expansion of the liver bud and commitment of the endoderm to a hepatic cell fate. So mutations in GATA6 can cause pancreatic hypoplasia or even complete agenesis of the pancreas. Those affected obviously have permanent diabetes mellitus, and they can also have abnormalities in other cell lines that are derived from endoderm and require GATA6. So that includes cardiac malformations. Hepatobiliary malformations are probably the most commonly seen comorbid conditions, and that can include something relatively mild like transient cholestasis versus gallbladder agenesis and biliary atresia requiring, transplant. Patients, because they have hypoplasia or agenesis, require both endocrine and exocrine pancreatic replacement. And again, because many of the tissues in our brain require GATA6 for fetal development, neurocognitive deficit is quite common in children who have GATA6 haploinsufficiency. And let's talk a little bit about autoimmune neonatal diabetes mellitus. So autoimmune diabetes mellitus is very rare before 6 months of age, and if present, it's usually linked to a specific cause, such as something like IPEX syndrome. IPEX syndrome is a monogenic form of autoimmune diabetes. It's caused by mutations in FOX3, and you have a clinical triad of watery diarrhea, endocrinopathy, which is most commonly insulin-dependent diabetes mellitus, but might include autoimmune thyroid disease and eczema. Typically, you would expect, it's X-linked, by the way, sorry, so you would expect this to be seen or should be suspected in male infants if they have a history of immune dysregulation, frequent infections, diabetes mellitus, and treatment. While initially management of diabetes is with insulin, ultimately treatment is with bone marrow transplant. And then I wanted to talk a little bit about trisomy 21. So we know that patients with Down syndrome are more likely to have childhood diabetes mellitus in general. This also includes presentation with neonatal diabetes mellitus. And so we know that trisomy 21 is probably associated with autoimmune diabetes that is not HLA associated. So in one study, there was a cohort of patients with permanent neonatal diabetes mellitus, and they found that trisomy 21 was 7 times more likely to be seen in that cohort than in the general population. And none of the Down syndrome patients affected by permanent neonatal diabetes mellitus were found to have a genetic mutation known to cause permanent neonatal diabetes mellitus. So if we have a child that's presenting with neonatal hyperglycemia, then what should we do? As far as evaluation is concerned, we should start by ruling out any contributing factors for hyperglycemia. And part of that is going to be calculating the glucose infusion rate, so the amount of glucose that infants are receiving from dextrose-containing IV fluids or from their TPN. The ideal glucose infusion rate to support adequate growth and nutrition for a neonate is about 6 to 12 milligrams per kilo per minute. And so you should calculate that. And if it's higher than that, then the first step is likely to try and reduce the GIR and see if your blood sugars improve and subsequently normalize with reduction. Of course, you should look and see what medications are being used, and any of them might be contributing to hyperglycemia. So of course, glucocorticoids. Oftentimes infants in the NICU are on vasoactive drugs like norepinephrine, epinephrine, dopamine, and as long as you're safely able to do so, you should try to reduce the doses or eliminate those medications as much as you possibly can. If no iatrogenic cause for hyperglycemia is found, then you should proceed to lab evaluation, which should include serum glucose, hemoglobin A1C, C-peptide levels, insulin, urine ketones, and kids older than 6 months old consider pancreatic antibodies, and then genetic testing. An ultrasound of the pancreas is also important, again, to assess whether the pancreas is present and if it's normally sized. In children with neonatal diabetes, the A1C and C-peptide are typically lower than seen in children who are presenting with diabetes at greater than 2 years of age. And that's really just indicating that there's much more rapid beta cell destruction in this patient population. In all children less than 6 months old, genetic testing should be sent immediately. As soon as, essentially, if you're starting insulin therapy, then you should send genetic testing. In children who are 6 to 12 months old, genetic testing should be sent if pancreatic antibodies are negative. And it should be considered if there are additional features suggestive of monogenic diabetes. So if there's any comorbid conditions, or there's a family history certainly suggestive of neonatal diabetes, then absolutely would want to consider genetic testing. Typically, the median time for results of genetic testing is about 8 to 10 weeks. And we've talked about how the results of that testing can be really important from the standpoint of therapeutic considerations. And so it's important not to delay therapy or to delay testing, just knowing that the amount of time that it takes to get the results. The treatment, just the basics we talked about. First of all, adjust the glucose infusion rate. Treat any underlying conditions that are present, such as sepsis. Decrease the dose of or discontinue any medications contributing to hyperglycemia as safely able to do so. And then in children with concomitant dehydration or any electrolyte disturbances, you want to replete fluids and replace electrolytes. We all know that. But then we come to insulin therapy. So most neonates are initially treated with an insulin drip. The starting dose is typically about 0.02 to 0.05 units per kilo per hour. And then you would titrate the dose by about 0.01 units per kilo per hour to maintain a blood glucose between 100 to 200 milligrams per deciliter. The transition to subcutaneous insulin should occur once enteral feeds have been firmly established. And once you transition to subcutaneous insulin, one of the most important things is going to be monitoring of blood sugars. Typically, you would want to monitor the blood sugar prior to each feed. If there's enough subcutaneous fat present, then continuous glucose monitors can be hugely beneficial because, of course, neonates are at very high risk for hypoglycemia. But certainly, at a minimum, monitoring the blood sugar prior to each feed. There should be very cautious administration of insulin, again, because of the risk for hypoglycemia in infants and because they oftentimes don't exhibit many symptoms of hypoglycemia. So it's easy to be missed if glucose monitoring is delayed. You should administer insulin if you're being very cautious, perhaps prior to every other feed. And the minimum blood glucose for administration of glucose is probably about 200 milligrams per deciliter. Some references will actually recommend waiting to administer rapid-acting insulin until the blood sugar is 250 milligrams per deciliter. The starting dose for rapid-acting insulin is about 0.1 to 0.15 units per kilogram per dose. And then based on your blood sugar trends, you can consider initiation of basal insulin at a dose of about 0.2 to 0.4 units per kilo per day. Usually the total daily insulin requirements can vary from anywhere from 0.29 units per kilogram to about 1.4 units per kilogram per day. It's best to avoid any sort of intermediate acting insulin, NPH, regular insulin, just because of the risk of hypoglycemia and because it's much more difficult to achieve adequate glycemic control than it is with long-acting and rapid-acting insulin regimens. We still encourage mothers, if they wish to breastfeed babies with neonatal diabetes mellitus. In general, breast milk contains about 2 grams of carbs per ounce, but it can be really difficult to assess exactly how much volume an infant is getting if the mom is breastfeeding, right? And so we don't necessarily count carbs and dose insulin for the carbs, especially initially. Rather, just give high glucose corrections based on the glucose trends. And then, of course, insulin dosing can be titrated slowly based on the overall trends. And over time, you might be able to get to the point that they're getting insulin with every feed, especially as the feeds are spaced out. So we frequently have to use diluted insulin in neonates. Obviously, neonates have relatively low insulin requirements, and the risk of hypoglycemia is significant at typical doses of U100. The lowest dose that we can give of U100 insulin via subcutaneous injection is 0.5 units. Sometimes use of an insulin pump can allow for dosing of smaller amounts of insulin, but infants who have monogenic diabetes oftentimes have a very small, they're oftentimes small for gestational age or IUGR because of the critical role that insulin plays in fetal growth and development. And so they usually have a pretty small body surface area, and that may limit the use of continuous glucose monitor and insulin pumps in very young neonates and infants. So if you dilute insulin, you can give doses as low as 0.1 units when it's diluted to U10, so about 1/10 of the original concentration. And then the question becomes, well, how exactly do we dilute insulin? So we have to kind of go back to our high school and college days, chemistry, and remember that C1 times V1 equals C2 times V2. So if you have U100 insulin and you're trying to make U10 insulin, 1 ml of that, you would take 0.1 mLs of U100 and add that to 0.9 mLs of diluent, and that's going to produce 1 ml of U10 insulin. Diluent itself may be purchased directly from insulin manufacturers. So both Lilly and Novo, I believe, actually offer free diluent. You just have to call them and request that they send it. They typically won't send it to like a patient's home. So usually it has to be either a doctor's office or a pharmacy. And it should also be noted that not all insulins can be diluted. And so rapid acting insulin can be diluted, but basal insulin should not. So Lantus and Levemir, as we all know, part of how they work is by maintaining a certain pH. And so if you dilute them, then because diluent is a buffered solution, it's going to alter the pH of those medications and then render them essentially useless. And so you cannot dilute any insulin, but if you wish to do so, then you can get diluent for free from essentially any manufacturer. Once you can actually produce, by the way, also I looked it up on Amazon, you can buy sterile vials on Amazon if you would like to, but you can get those from the manufacturer as well. And then once insulin is diluted, it's typically must be discarded within about 2 weeks of dilution. And so this has to be something that's done once every 2 weeks. So families can be taught, or sometimes you can find pharmacies who will do it for you.
Thank you.
So sulfonylureas are effective in treating neonatal diabetes in infants with mutations in the potassium-sensitive ATP channel. They may also be effective in infants with chromosome 6 mutations. You find that in patients who are sulfonylurea responsive, you oftentimes have better metabolic equilibrium when using sulfonylureas compared to insulin. You normalize the hemoglobin A1C more quickly. You strongly reduce the incidence of hypoglycemia. And again, because of the number of sulfonylurea receptors in the brain, treatment with sulfonylureas may also improve neurocognitive functioning. Typically, the earlier you start sulfonylureas, the more improvement you're going to have, or the less neurocognitive comorbidities are going to develop for infants. So early initiation is actually superior. It is important to kind of let families know though that there may not be complete resolution of neurocognitive deficits, and that's thought to be because the medication doesn't fully cross the blood-brain barrier. Unfortunately, about up to 10% of patients with KCNJ11 mutations may not respond to sulfonylurea therapy. There's not really a good way to know who's going to respond and who's not going to. You just sort of have to try and see what happens. Given the delay that's often present between clinical and genetic diagnoses of neonatal diabetes, the current expert consensus actually recommends empiric trial of sulfonylurea therapy. So we know that mutations in the potassium-sensitive ATP channel are the most common cause of permanent neonatal diabetes. So there's a pretty good chance that the child is going to have one of these 2 mutations. And so going ahead and starting the sulfonylurea empirically, knowing that earlier initiation can have such a positive benefit as far as neurocognitive comorbidities, that's the expert consensus right now. In patients who have pancreatic hypoplasia or agenesis, If there's any syndromic features or if there's history of consanguinity, then the trial should be deferred. In the patients that are not responsive to sulfonylureas, then typically lifelong insulin therapy is going to be required. So this is just an algorithm to kind of help determine when to try sulfonylureas. So if you have a child who's diabetes mellitus that's diagnosed under 6 months of age, first of all, establish euglycemia, get urgent genetic testing, obtain an ultrasound to determine whether the pancreas is present or not, evaluate for any consanguinity or syndromic features. If not, then consider an empiric trial of sulfonylureas. If there is hypoplasia or agenesis of the pancreas, or you have other comorbid features that point you towards a different mutation, then await the genetic testing results. Of course, if you have a successful trial of sulfonylureas, then you would want to ensure that you follow up on the genetics and that a genetic diagnosis is firmly established. And there's actually guidelines on how to initiate sulfonylureas as well. So typically, sulfonylureas, the lowest dose that they're available is 5 milligram tablets. Glyburide is the preferred agent. Sulfonylureas can be crushed and readily prepared in aqueous solution, so you can mix them with either normal saline or just like formula or breast milk. And the tablet can be cut as small as 1/4 of a tablet. So the lowest dose that you can use is about 1.25 milligrams. I do want to note that the use of sulfonylureas is actually off-label in neonatal diabetes mellitus, but we do it anyways. So prior to initiation of the trial, you want to make sure that you're monitoring the blood sugar closely, typically before meals, 2 hours post meals, bedtime, overnight. If you're on an insulin pump, you can maintain the same basal bolus regimen. And then the morning that you're starting the trial, reduce the basal insulin in the pump by about 50%. If you're on basal injections, then the night before you're starting the trial, you would cut the basal dose by about 50%. Typically, the starting dose for sulfonylureas is about 0.1 milligrams per kilo, and it's dosed BID, so a total of 0.2 milligrams per kilo per day, and you would dose before breakfast and then usually before dinner. So on day 1 of the trial, monitor blood sugars. Before breakfast, you give the initial dose of sulfonylurea. You would continue to administer rapid-acting bolus insulin as needed for high glucose correction based on the capillary blood sugar. Might want to avoid giving a bolus, though, within about 2 hours of the glyburide dose. If it's been 2 hours and you want to give insulin, then you might give about 50% of the usual insulin dose. Continue to monitor blood sugars. If the blood sugar is greater than 200, so I guess if your blood sugars are persistently remaining above 200, then you can continue to titrate up the dose of sulfonylureas by about 0.1 milligram per kilo per dose. And so each day you're going to increase by 0.2 milligrams per kilo per day and continue to decrease your basal insulin as able by 50% or discontinue it. And decrease your bolus doses by about 50%. Oftentimes, the doses are optimized or maximized to about 1 milligram per kilo per day, but some infants will need higher doses, anywhere up to 2 to 2.5 milligrams per kilo per day. If it's unclear whether infants are responding to sulfonylureas or not, then you can actually check a C-peptide level about 90 minutes to 2 hours before a dose of glyburide and before a feeding. Feed, give the glyburide, and then check a C-peptide level 90 minutes to 120 minutes afterwards. If you see an increase in C-peptide after sulfonylurea administration, then you can reasonably expect that the infant is going to respond to sulfonylurea and continue to titrate up the dose. Oops. If there's no increase, sorry about that, then the likelihood of response is low. And so this is something that can take anywhere from about 2 to 7 days as far as determining whether an infant is responding to therapy and then getting them on an optimal dosing regimen. Most often this is done inpatient during, with close observation. But if you are very gutsy, you could try to do it at home with a family. The long-term follow-up. Infants with neonatal diabetes mellitus should be seen for follow-up at least every 3 months. Hemoglobin A1Cs of note may not be reliable to monitor glycemic control during the first 6 months of life, and that's because of the high concentration of fetal hemoglobin during this time period. But screening for microvascular and macrovascular complications typically is delayed until at least 5 years after diagnosis. Let's go back to our clinical case. So the initial infant, once taking consistent PO feeds, the patient was transitioned to subcutaneous insulin. She was started on a regimen of Levemir 0.5 units BID and insulin lispro diluted to U10. Blood sugar was monitored prior to each feed every 3 hours, and rapid-acting insulin was administered prior to every other feed. An empiric sulfonylurea trial was initiated. She had very poor response. Blood sugars, as we were backing off on insulin, blood sugars were remaining 200s to 400s, even with as-needed glucose corrections. So we did end up getting a pre-feed C-peptide, which was low at 0.3, and the post-feed C-peptide level was also 0.3. So at that point, the trial was discontinued. She had genetic testing sent, I'm going to say, like 1 week of life, and eventually it resulted as showing heterozygous for or an autosomal dominant mutation in the INS gene. And our second clinical case, which was the young lady with trisomy 21, after a resolution of DKA, this patient was transitioned to subcutaneous insulin therapy. Because she was older, a little bit bigger, she was actually able to use insulin lispro U100 and Lantus. She was breastfed ad lib. Blood sugar was monitored every 3 hours and insulin corrections given prior to each feed. She was ultimately found to have positive GAD and IA2 antibodies. She did have genetic testing sent, and it was negative. So in summary, neonatal diabetes mellitus is a rare condition presenting in the first year of life. It is most frequently caused by genetic mutation, and a number of disease-causing mutations have been identified. Clinical features are often determined by underlying genetic mutation. Treatment is with insulin, but sometimes sulfonylureas may be utilized. And that's it. Thank you. I'm happy to take any questions. And then today's event code. Okay. Okay, anyone have questions?
So nowadays we rarely use glyburide at all. So you have enough glyburide available?
We don't generally carry it actually at the children's hospital, so we had to get it sent over from the adult hospital. Okay. But that was easy enough to do, and then our pharmacy compounded it for us.
So there are studies that look at differences.
I honestly didn't dig that deep into like the specific sulfonylurea. So I don't know if there's different ones that have been tried, but I do know that most of the studies that have been done have used glyburide. So that's generally the kind of the go-to. Even for our patients that have MODY, we most often will utilize glyburide over any of the other sulfonylureas. So.
Because one of the concerns glyburide sort of hypoglycemia rates are different. Also,
so I don't know about the different sulfonylureas as they relate to neonatal diabetes, but I do know that there's certainly lower rates of hypoglycemia in sulfonylurea responsive patients when they're using the sulfonylurea compared to insulin, for sure. Yeah.
I have a question about this.
Yeah.
Where do you get the genetic testing?
There's lots of different places that you can do it. So some of the just like industry, like genetic testing, like Blueprint Genetics has a panel for MODY and for neonatal diabetes. Seattle Children's actually has a panel. A lot of the monogenic diabetes testing is done both for MODY and neonatal diabetes at University of Chicago as well. And so there's a variety of different places. And for us, like I think we sent for this child, it ended up getting sent to Blueprint Genetics, and we just kind of looked up to see what's the turnaround time and what's the cost, and tried to pick the one that was going to be the most sort of cost effective and get us results as quickly as possible. But there's a number of different panels out there.
What type of panel?
Yeah.
They only do like 4 of the most common
Yeah.
promoting.
For Modi.
But it's always a cost thing because sometimes insurance covers it.
And sometimes it
don't.
doesn't. Yeah.
You know how much approximately the
I
I think
don't-
Seattle Children's one was like 3 to 4. That's how we did it.
University of Chicago, it's free.
It's free.
But it's part of a study. So it may take months to years before you get it back. For at least pediatrics, some of the, if it's medic, if they're like state insurance, usually it's like covered under them.
Yeah.
Some of the companies have made a deal where like the max out of pocket is like 200, 250. But that's not all of them.
It's
But
a
even $200
yeah.
for some of our families.
It's honestly a little bit more challenging for like, neonatal diabetes is so rare, and I don't know that any insurance company is gonna like be like, no, you can't get genetic testing on this baby that, needs insulin or whatever. But for Modi, it can be a little bit more challenging, and sometimes we really have to jump through a lot of hoops to get that test. If you have a family member who has like a confirmed diagnosis of Modi, then sometimes it's easier, and you can do targeted genetic testing. So you know what the specific mutation is, and you only test to see if that mutation is present. But, sometimes there's a strong family history, but nobody else has actually been diagnosed yet. And then it can be a little bit more challenging.
How long have these people been trying to find out?
I mean, there's definitely cases from decades ago, but it's so rare, and each mutation is so rare. That's really the problem, right? Is that there's just not enough cases to have so most of the studies you look at, like the biggest cohort I saw was like 1,020 patients, I think, and that was across all mutations. And so, it's usually double digits if you're lucky as far as the cohorts. And so it's not necessarily like the duration, it's more the numbers.
Is that an ICD code for
Mm-hmm.
neonatal diabetes seems like a generic term. So when they like grow into teens and adulthood, do they share that nomenclature, and do we start calling them differently based on the mutation?
No, I don't think so. I mean, you might say monogenic diabetes mellitus as opposed to, so monogenic diabetes mellitus diagnosed in infancy or something like that, like in your documentation. But no, I mean, they were diagnosed like as neonates, and they have neonatal diabetes.
I don't think in Epic you will get it. But look for it.
Yeah, you can find it because we definitely
But
built for it.
not
But,
big.
and again, it's neonatal hyperglycemia is common, neonatal diabetes is not. And so it sounds like a generic term, but it's not really one. It's not a code that we use very often, right? Because we have lots of kids that have mild hyperglycemia, or even it's moderate hyperglycemia, but it resolves quickly, or that there's a clear sort of etiology to explain it, and once their sepsis resolves, their blood sugars improve. Kids who require insulin therapy, like neonates and infants who require insulin therapy because of the extent or the duration of their hyperglycemia, that's much more rare. Much more rare, yeah. Oh, sorry. Yep. How many don't get diagnosed in time for treatment? Could you specify what you mean by in time for treatment? You mean to prevent like neurocognitive comorbidities? Yeah. Yeah. I apologize. I'm not sure exactly. Long time before they receive treatment. So it's rare, but I don't know that it's missed that often because it's usually the presentation is quite severe and significant. So the vast majority of these infants, even the ones that are sulfonylurea responsive, initially, their hyperglycemia is dramatic. So this baby that, that came into the ED, again, blood sugars were in the 500s. So you know that a baby who has that type of hyperglycemia is not going to gain weight, is going to be certainly like irritable, is not going to be clinically well appearing. So even though they got sent home from the newborn nursery, they came right back to us because of how poor they looked at their newborn visit. And then you're going to start them on insulin therapy. So, and if they don't present, within that first week of life or get picked up in the newborn nursery or at their initial well-child check, the likelihood is that they're going to present in diabetic ketoacidosis, right? And so we're probably going to catch them sometime in the first couple of weeks to months of life, just because of how rapid their beta cell destruction is and their lack of insulin production.
And we do have patients who will ask them how long
Yeah.
and hope to get them to tell us exactly when they just start.
Exactly. Yeah, sure. And I mean, I think that, some of the forms of MODY can have, if you have a glucokinase mutation or something like that, those obviously can go underdiagnosed, or some people get misdiagnosed as type 1 diabetes at a young age. But as far as like neonatal diabetes, like presenting in the first 6 months of life to 1 year of life, these kids, they don't make insulin, so they're not going to grow. They're going to come in DKA. They will be picked up.
There was an interesting.
Mm-hmm.
He's the one who, and they thought that like that is not going to regulate secretion. After they found MODY was the convincing proof that he was right.
Yeah.
They could show that. But he died 93.